who I had the pleasure of meeting Zoom face to Zoom face for the first time yesterday. Megan Sellick is a palliative care physician who joined the team, the Thunder Bay team, in April of 2022. And she graduated from Dawson in 2012, then moved to Edmonton for her family medicine residency, which she completed in 2014, and her palliative care residency completed in 2015. She then worked 7 years in Edmonton, mainly on the tertiary palliative care unit and the symptom control and palliative care team at the Cross Cancer Institute. And her clinical work focuses on caring for patients living with life-threatening cancer diagnoses. Academically, she is an assistant professor in the Division of Clinical Sciences at Dawson University and has maintained an assistant adjunct professorship in the Division of Palliative Care Medicine at the University of Alberta. She is also a fellow with the Royal College of Physicians and Surgeons in palliative medicine. And in addition to her clinical work, she is involved in medical education, such as today. So thank you very much again, Megan, for being here, and I will turn it over to you.
Fantastic, Stephanie, thank you. I'm just going to do the quintessential Zoom thing and beg you guys to be patient with me while I attempt to share my screen. And the way I have it, I don't know that I'll be able to see chats that pop up as we go. So Stephanie, if people are putting stuff in the chat and I'm accidentally ignoring it, please feel free to interrupt and pipe up. So I am just going to get going. So I wanted to situate you guys in my context, sort of to first start out, just because I do know that there's some geographic variation in how we prescribe things, how we approach things, and in palliative care in general. And so I'm coming to you guys having lived and worked in Edmonton for, I was there for about 10 years, all told, but I was raised here in Thunder Bay. So I'm familiar with Thunder Bay, but haven't practiced medicine here until April this year. So I carry some of my Edmonton training with me, and I'm hoping to share that with you guys today as depending on its pertinence. The other thing to mention is I am a specialist in palliative care, so I don't practice primary palliative care per se, but I bring this specialist level to my work. And I had a chance to have a peek at the registration list. So I think I've got a bunch of people in nursing and management and case management and nurse practitioners on the team here. So please, my hope is that this talk will be basic and complex enough to meet everybody's needs, but I know that I probably can't meet everybody's needs all at once. So what I'm hoping is that this will spur some interest. And if there's a particular area that you want more information, reach out, or maybe I come back and do another talk in another while on something more specific. So keep that in mind and keep that percolating as we go through this. I want to start by just commenting on pain in general. Patients will be referred to me for pain management strategies. And what we all need to remember is that our patients will have pain from multiple sources. And the reason this is important is because I may not be the best person to manage their pain depending on what's causing it. So patients will have pain directly related to their tumor. So a cancerous deposit in a bone causing severe somatic bone pain. Patients can also have pain related to their cancer treatment. So these are the patients with peripheral neuropathy from the sort of neurotoxic systemic treatment that they've been taking. And patients will also have pain completely unrelated to their cancer. So degenerative disc disease, chronic shoulder pain from a rotator cuff injury or an MVA. So these are all the things that we have to keep in mind. And what I'm hoping is by the end of this talk, you'll have a sense of how I approach a patient and their context so that I can tease out which of these pains they have, because the first two, that's my wheelhouse. The chronic unrelated to cancer pain, not necessarily my wheelhouse. I can sometimes stopgap help for a bit, but really that's in the chronic pain wheelhouse. So I'm hoping to dispense forth some information and some my approach to how I assess a patient and their pain. And if I'm too basic and you guys want more detail, pipe up. If I'm kind of glossing over something you want me to dive deeper on, just let me know. So I want to start with a case. I'm going to tell you about Jill, and just for context, Jill is fabricated, but she covers a lot of areas, and so we're able to follow her through her cancer journey. So Jill is a 42-year-old woman. She lives alone. She has widely metastatic triple-negative breast cancer, and she's referred to you for pain. You're told on the consult sheet she does not want opioids, but maximum doses of acetaminophen and ibuprofen have not been working, so please help. And that's all you get. So my approach is I start by just taking a history. And I still, to this day, for my complex patients, will use a mnemonic. I really like the mnemonic OPQRST. It helps me remember to ask about onset of the pain or symptom, what makes it better, what makes it worse, what the timing of it over the course of the day or week is. Has this ever happened to them before? Are there other associated symptoms? It really just helps kind of make sure you're covering all the bases. Specifically, when it comes to pain medication, I spend a lot of time getting the specifics about what people do. I'm sure we've all encountered the patient who says, well, I take 1 or 2 tablets of that pill that I was given, every 3 or 4 hours if I need it. At cursory glance, that's helpful, but in actual fact, that is not a helpful statement for me. 1 or 2 tablets of what? And was it a 5 milligram strength tablet or a 10 milligram strength tablet? And when you say every 3 or 4 hours, if you really need it, how often do you actually need it? So what I'll do with patients is, if some people keep a pain diary, so we pull it out, we have a look at it. Other people don't, but I'll specifically get them to work with me through the last 24 hours of their life. What time did you wake up yesterday? What did you take? Did you take 1 pill or 2 pills? Show me the pills. So that, it seems little probably, and it probably seems basic, but that's probably where I spend a lot of my time, because I can't increase a medication if I don't know where we're starting from. So I'll ask home care nurses this level of detail, like exactly what did they take at exactly what time, because that's how we keep our patients safe. The other thing I'll do is I'll use an assessment tool, and you'll recognize it probably when I show you in a minute. I perform a physical exam. So in real detail, I look at the area that hurts. So I examine if it's a femur that's in pain, I palpate the area. I get them to move it for me. I assess their strength. I assess their sensation. I assess their reflexes. You're trying to figure out if the pain is a nociceptive pain or if the pain is a neuropathic pain, because we would treat them differently. We would manage them differently. And so unless you examine, unless you touch and assess it, you won't know what else is going on. So you really need to do that. And then I will have already looked at the imaging before sitting down with the patient. But after I've done all of this, spent this, many, many minutes taking the history, asking the specifics about the pain medication, and doing the physical exam, I go back and I look at the imaging again, because this is where you can overlay what you already know about where their cancer is with what they're presenting with today. And so it's important. When was the last set of even plain films done of the area that hurts? When was their last CT for staging? When was their last MRI or PET scan? And sometimes what this means is I have to update the imaging. If I see a patient who has new left femur pain and I don't have any imaging of the femur to know if there's Mets there or not, I need to get imaging so that I can better understand what I'm treating, and make sure I'm not going to give opioids to arthritis. So those are the important things to pull together. So if we come back to Jill, Jill has central back pain and pain in her left femur. Her back pain is described as a constant, dull, achy pain that's been there for weeks. It doesn't change. It's always the same. She's rating it at about a 4 to 5 out of 10, wishes it was closer to 2 to 3, but 4 to 5 is okay. Her left femur pain is intermittent. When she's resting, it's only a 2 to 3, but as soon as she stands up and puts any weight on it, it shoots up to an 8 or 9 out of 10. She's having a hard time these days walking her dog because of that pain, so her neighbor has started doing this for her. When you go back and examine her and then look at the imaging, you can tell that her back pain is correlating with a place in her spine where she does have metastatic disease, but you've done your full neuro and strength assessment and you're not worried about spinal cord compression or nerve root compression, because you have to keep that in mind. And the left femur, there's evidence of a large metastatic deposit there, but the radiologist has commented that there doesn't seem to be a risk of impending fracture, but you're going to keep that in mind too. So here's the ESAS. I'm sure you guys have seen this. I'm a little bit biased because it was developed in Edmonton by my colleagues. But what I will tell you about it is a really helpful tool. So I've just snapshot the first line of the ESAS instead of all 9 items, because I want to highlight a couple of things here and how I use the ESAS. I think it's easy for us to look at the ESAS and think it's just a screening tool. I do it as part of my initial assessment, and then I might not look at it again. But I really do use this, and this is what my ESAS is when I do them with patients end up looking like. So I'll have a circle and an arrow saying 5 out of 10 right hip pain. That arrow along the bottom shoots out to 10 out of 10 with walking. The low back pain is a 2. It doesn't change. The personal pain goal, PPG, is a 3. So all of that gives me targets. 2 things else I want to say about this. One of the most important things you can do with the ESAS is anchor it to your patient. So if they give you a number, your follow-up question needs to be, for you, is that number mild, moderate, or severe? For most people, mild to moderate will shift around 3 or 4, and severe will appear somewhere around a 7 or an 8. But I've cared for patients where anything above a 3 was considered severe and intolerable. But I've also cared for patients where anything under 8 was mild. So we don't know where we're going, kind of like the meds, if we don't know what we're anchoring. So if a patient says it's 5 and they're content with that, we make a plan for what happens if it gets worse, but we may leave well enough alone. The other piece that's really important is to denote who gave you the numbers. So as long as the patient is the one verbally giving you the number, even if they're too weak to circle the numbers themselves, I would consider that patient reported. The reason this matters is because the research is pretty clear that healthcare providers and family members are not particularly accurate at assessing a patient's level of pain, but it's still better than nothing. So if I see that the numbers have all been provided by a family caregiver, I still look at that, I still value that, but I would value it differently, slightly differently than if I knew it was coming directly from the patient. So those are just things to also be keeping in mind about this tool. I love this tool. Yeah. Other things that we need to consider when we are preparing to manage someone's pain is we need to have a sense of their kidney and liver function, because that will dictate how often we can dose the meds. We need to know how frail they are and what kind of home supports they have. Are we starting this in a home and patient has no one around them, so we might want to be more careful? Or do we have them on an acute pain ward and they're being managed by highly skilled nurses and we can be a little bit more aggressive because the nurses know what to watch for? These are all the things that I consider before I write the prescriptions. You also want to keep in mind someone's psychosocial well-being. Are there other things playing into the pain that you might want to be thinking about? Do they have a history of addictions where they might have difficulty with pain meds being around them? And what's their cognition like? Because through no fault of their own, cognitively impaired people struggle to keep track of their meds, keep track of their pain, provide an accurate history. So these are also things that can make pain particularly challenging to manage. So we come back to Jill. We know that she lives alone. Her kidney function and liver function are okay. She's quite robust, all things considered. She would walk her dog every day if it wasn't for this pain, for example. She does have a sister, but her sister's out of town, checks in every day by phone. So her sister would know if something was up, but wouldn't be able to get there in a hurry to help. And she does have home care case management who's checking in on her every week and is ready to step up services whenever the time comes. Jill tells you her mood is good. She's got a good outlook. There's no history of addictions, and she's cognitively sharp as a tack. So those symptoms, those things that I've just described to you fall into a new tool that maybe some of you have heard of. And I'd be curious if I could figure out how to look at my chat while I'm talking to you. I'd be curious to know if any of you have heard of the ECSCP before. So this stands for the Edmonton Classification System for Cancer Pain. So it's less widely known than the ESAS. It's only been around for about 15 years, maybe 12, developed in Edmonton. We name things after ourselves out there. And this looks at 5 domains that make pain challenging or complex to manage. It's just 5 things to stop and think about. So if you're dealing with a patient's pain and you can't get a handle on it, you feel like there's something that you're missing, come back to these 5 things, because this can help you pull it apart and tease it apart. So it's only been validated in cancer patients, but what we were doing in Edmonton was we were still considering these 5 things in anybody that we saw in consultation within our Edmonton Zone program. So the 5 things are the mechanism of pain. So we know that neuropathic pain is harder to manage than nociceptive pain. Incident pain, which is pain with any kind of activity or movement, whether it's predictable or unpredictable. And the definition that we use for this tool is pain that gets worse by at least 2 points on the ESAS with that activity or movement. Could be bladder spasms, could be getting up and walking, those kinds of things. That's more challenging to manage than pain that's always the same and doesn't change. Psychological distress that contributes to how a patient expresses their physical pain. This is harder to manage too. I'm sure most of you, but maybe not, have heard of this concept of total pain, this idea of the multidimensional aspect of pain, that patients will say to us, I'm in pain. And what they mean is I'm globally suffering, but it gets reported as pain, and they want analgesics for it because it's pain. But more and more opioids isn't necessarily going to manage this kind of suffering, this kind of pain. And so it's just something to be on alert for. Patients with an addictive behavior, previous history of addictions to any kind of substances, they can have a more challenging pain syndrome, only in the idea that it can be harder to try to keep them safe. It's not to say that we don't give them opioids. It's just that we give them opioids in a more controlled, safe way. And so it's important to have an understanding of what their addiction history might be. I'm upfront with patients and I ask them if they're worried about themselves or anybody in their immediate family having access to these medications, if that would put anybody at risk. And I have encountered patients over the years who they themselves don't have issues, but there's somebody in the home that they worry about. So those are things to keep in mind. And then, as I already mentioned, cognitive impairment. So what you end up doing is you build this tool, and I would happily come back and talk about it in a lot more detail, because this could be a whole 30-40 minute conversation all on its own about how we really use it. But I just want you guys to take away that these are 5 things that can make pain really challenging to manage. And it's just a reminder of how to come back and think about them. So for Jill, her pain is pretty straightforward at the moment. She's got a nociceptive pain from her bone mets. Doesn't seem to have a neuropathic component at the moment, but she's got this left femur incident pain, so pain that gets worse with that walking. So what I would ask you is, if she was recovering from substance misuse or didn't have any family at all and didn't want any kind of care and support, she was cognitively impaired and therefore a really vague historian, or she was living with total pain, those things would complicate her pain syndrome and therefore our management of her pain. So those are things I think about. But then when it comes time to actually sit down and prescribe, there's a few more things to give pause and to think about. So where I'm going with this is, how do we start opioids? But the first thing I think of is a non-opioid been tried? And is an opioid even the right choice for the pain that this patient is having? If you haven't tried other opioids, but the patient has really severe pain, you can skip the first step of trying non-opioids and go straight to opioids. But traditionally, we would start with non-opioids first. If a patient is presenting with mostly neuropathic pain, you might want to consider starting with a neuropathic agent specifically out of the gate instead of an opioid. So those are the things that you want to be thinking about. You also want to think about the duration and frequency of the pain. If the patient is only having pain a couple of times a day with an activity, then you would start off on as needed dosing. If a patient is having unrelenting constant pain, you would be starting off on scheduled dosing. So those are the things, that's why those considerations matter. My biggest recommendation is start with a single opioid at a time. Start really low and go slow. And I'm going to sound like a broken record because I definitely have that on another slide coming up. You want to think about the support system. I already talked about this, but are we starting this in home where a patient lives alone? Or are we starting this in a hospital where they've got, skilled nursing taking care of them? And then, as mentioned, does the patient having opioids in the home put themselves or anybody else at risk? And then the final thing, which is why it's bolded at the bottom, don't forget that before you start treating pain, you need to understand it so that you know that you're not missing an emergency. And we do have emergencies in our world. We've all seen them. And those emergencies, particularly with cancer patients, are delirium, fracture or impending fracture, and spinal cord compression or nerve root compromise. So you want to make sure that before you're treating it, that you know what it is. And you can treat it, if you know it's spinal cord compression, you can treat it while you're treating the cord compression issue, but you don't want to mask it and blindly not think about the broader picture. So you guys all know this, opioids, this is my approach. Opioids come in two major forms, oral and injectable. I really like, so if the gut is working and the swallowing is working, go with oral, it's so much easier. You can use liquid oral preparations of morphine or hydromorphone if you want to get tiny, tiny doses. Otherwise, starting with the short-acting immediate release tablets is my go-to. I rarely start people off on long-acting. Most of the time that I'm starting somebody on opioids, completely naive, I start them on a PRN dose only of usually the lowest dose I can get. So 2.5 milligrams of morphine or 0.5 of hydromorphone. And once they're settled and stable on that short acting dose and I know what they're going to need, if it converts nicely to a long acting formulation, then I'll make that switch because it's easier for everybody. But I almost always start people on short acting doses. If you want to go injectable, my preference is subcutaneously. I don't find IV to be particularly better. If they have an IV access and that's the route you're going, that's reasonable. But my preference with sub-Q is that you get a better curve. So the drug doesn't peak in the body and drop off in the body quite as quickly as when you do sub-Q. You get a longer duration, more of that Q4, more of the actual 4-hour lasting than a shorter if you're doing IV. Here's a big geographic variation. In Edmonton, we never used pain pumps. Ever. We always used intermittent injections. There has been some research done, and there's no evidence that a continuous infusion of an opioid is superior to intermittent injections. And just because of the landscape and technological landscape in Edmonton, we didn't have access to CAD pumps. So everything we did was intermittent injection. So that's just something that I'm wrapping my mind around coming back here is the use of the continuous infusions of some things at some times. So those are just things to keep in mind from my context. And you do have the transdermal route, but talking about things like fentanyl and buprenorphine is a whole other ballgame. So, and most of the time, our patients don't quite have the skin integrity that they might need for the transdermal systems to work well. I warn everybody about side effects. Everyone will be a little bit drowsy or nauseated for the first 5 or 6 days, and that tends to taper off after that. Everybody gets constipated, and that never goes away. Some people get itchy. I talk about addictions, tolerance, withdrawal, and dependence with my patients to make sure they know. And the take home for you guys here about withdrawal, tolerance, and dependence is that those are physiologic responses to just having the opioid in their system. So if somebody is taking a dose of, let's say morphine chronically for days and days and days, weeks, and they suddenly quit cold turkey, they will go through withdrawal. The withdrawal is not life-threatening, but it's pretty horrific. And so I try to prevent that for most of our patients by tapering, and that taper will look different for everyone. In general, the reason I mention this today is because the complexity here is if you have a patient who stops all of their opioids cold turkey, and then a week later realizes that the opioids were doing something and they want to restart, if it's been a number of days, you need to restart at a lower dose because their tolerance for that dose will be gone. And restarting at the dose that they stopped at could lead to overdose. So I know that's worded strongly, but that's just something that I really want you guys to be thinking about when you're out in the world caring for patients. Just remember that even though they might have tolerated morphine 10 every 4 hours for weeks and weeks, if they've been off it for a week, you need to start much lower than that. So here's my start low, go slow. I will typically start off on a PRN, and I'm just going to jump back to Jill. So my approach to starting an opioid is I name them all in front of the patient and see which one they don't panic over. And that's how I figure out which one they're going to be willing to take. So for Jill, she says she thinks she was on morphine at one point, happy to go back to it. So we start with a 2.5 milligrams every 4 times a day if she needs it. She's going to keep a pain diary, call me or the nursing team if anything changes, but come back in a week. She comes back in a week, she's taking all 4 every day and not having any issues, and it is helping her pain a little bit. Generally speaking, if somebody is taking more than 3 doses, a day for more than 3 days and they're not having any adverse reactions, it's an indication that you can go up on their dose. There will be times though where you won't want to. Either the patient will say to you, I'm really happy with what we're doing, can you leave it alone? Yes. If you think that they're taking their opioids because they're having total pain and total suffering and they're treating their physical and emotional state with opioids, I wouldn't increase their dose. And if they have exclusively incident pain, and no matter what you do, when they go for a walk 3 times a day, they're going to need their dose, I wouldn't change it. I would just accept that those doses will exist. When it's time to go up on a dose, general rules, we're going to increase the total daily dose of that baseline scheduled dose by about 20 or 30%. This is where there's some wiggle room. If somebody is really close to having well-managed pain, you might only go up by 10 to 20%. If their pain is horrifically out of control, you might go up by 30 or 40%. This is where the kind of clinical finessing comes in. You're also hogtied to what the tablet strikes come in. So that will limit the jumps that you can make. Couple of rules, I usually don't like doubling, but you don't really have a choice when you're on morphine 2.5 milligrams every 4 hours. You can't really do anything but go up to 5, though you could go from 2.5 every 4 hours to 5 every 6 hours. And that might be a bit of a more gentle increase. And I don't like increasing the dose. So if someone's taking 5 milligrams every 4 hours and they're taking 6 doses of their extra breakthrough doses as well, and we add all that together, I don't like to schedule that. I like to leave a little bit of wiggle room in the top where we're not quite giving them exactly what they've been taking every day. I just find it a little bit protective against side effects and potential overdose. So for Jill, we take her from her as needed schedule to true scheduled dosing. And you'll notice in all of my recommendations, I really prefer dosing on the hours as opposed to how many times a day. I find that if we get people on a Q6, Q8, Q4 schedule, we find a steady state of opioid in their system. If someone's taking morphine every 3 hours, 4 or 5 times in the day, and then doesn't take anything for 10 hours, they're going to wake up in pain. But if I've got them setting an alarm and taking a dose every 6 hours, and they come to me and say, it only lasts for 4, and then I'm needing an extra dose, then I know that they can handle a Q4 dose schedule. So those are my kind of tricks, is to stick with scheduling by the hour as opposed to scheduling how many times a day. So we get her on a schedule. Typically speaking, that PRN dose that she would have access to 4 times a day if she needed it on top of the schedule, that should be about 10% of her total daily dose. But when we're dealing with doses this small, we have to use just the smallest that we can, which is still 2.5 every hour if needed. So now she tells us she's only using extras when she goes to walk her dog, and otherwise she's fine. Yes, so thank you, Aparna. I do have access to the chat. So when somebody is living with renal impairment, I usually start them off if I'm starting them on a schedule, I start them Q8 with the immediate release. And if they don't develop opioid toxicity on a Q8 schedule and they're having breakthrough pain before the next dose is due, I'll go to Q6. And sometimes I push it and try Q4, but usually with renal impairment, we're sticking with a Q6 schedule of the immediate release preparations of these opioids. And I've used all opioids in settings of renal failure. There is still a preference in the literature for some to use hydromorphone in the context of renal impairment, but I've successfully used oxycodone. I simply dosed at Q8. So those are things to remember. You can use any of them really in renal impairment, but I do see a preference for hydromorphone to be used. No problem, Aparna. So a couple of weeks later, Jill comes back to see us and things have changed. She's having a ton more pain. Her cancer's progressed and her oncologist has told her there aren't any other cancer treatment options. She's using all 4 of her extra doses, which she wasn't doing before, and she thinks she's needing more. So you'll remember we had her on morphine 2.5 every 6 hours. Now she's using 4 of those extras a day and wishes she had access to more. So her total daily dose is 20 milligrams of oral morphine. You'll remember I don't love doubling and I have all these funny rules, but I want to show you here that if we were to go to 20 milligrams a day divided in 6 doses for Q4, that's a dose I can't get, 3.33. So we have 2 options. You could go Q6, so you could say 5 milligrams every 6 hours, or you could do 2.5 milligrams every 4 hours with extras if you need it. So you can decide. Like I've told you I don't like doubling. I've told you that I don't like going to take into account all of their PRNs that they're using every day. So I would probably lean towards morphine 2.5 every 4 hours, because that's an extra 5 milligrams a day. But I would have really close follow-up with her. Like I'd be talking to her in a couple of days and bring her back to clinic, or seeing her in a home visit again in a week, because I want to get a handle on this. The other thing to think about for Jill is we know that she's got bone pain. So can we specifically use some adjuvants? Can we use steroids? Dexamethasone is a great choice. It reduces the inflammation around tumors and helps keep that pain at bay. Can we use bisphosphonates? Now those typically take time. We need weeks to see some benefit there. And the same goes for the neuropathic agents. We sometimes need weeks for the antidepressants like duloxetine to kick in, or for things like pregabalin and gabapentin to take effect. So if you've got weeks, those are reasonable approaches to neuropathic or bone pain. If you have days and someone's in really severe pain, you can use steroids instead. Other adjuvants, so please don't forget about radiation therapy. So even though Jill's been told you can't have any more treatment, I'd call RADONC and say, can you radiate her bony mets? Because that would help, I think. You know, reach out for the psychosocial resources. Make sure if she's having a lot of existential suffering that we've got social work and psychology involved. If you've got access to a music therapist, which we did on TPCU in Edmonton, we got them involved. OTPT for ways of, you know, energy conservation, exercise tolerance, those kinds of things. And don't forget about spiritual care as well. My big take home about any of the adjuvants that you might use is they are meant ideally to be opioid sparing. So if you start them and nothing changes about the pain, rethink whether or not you just contributed to polypharmacy or did make a difference. I would consider an adjuvant to be successful, even if the character of the pain changed. So if we had a patient with horrific lancinating electrical pain from brachial plexus involvement all the way down the arm, and the initiation of pregabalin stopped that, even if their opioid dose didn't change, I would take that as a win and continue it. So could she benefit from radiation? Could she have a short course of steroid? Could we do bisphosphonates? I would say yes to all of these things for Jill at this point. Other things like methadone if she had neuropathic pain, or fentanyl for incident pain, really, really short-acting incident pain. Those things could also be considered. And I will gladly come back and chat about methadone another day if you guys would find that helpful as well, because that's a 45-minute talk unto itself. And then I know I'm out of time, but I just want to comment here because the last stage for Jill is now her sister has moved in, her dog has been given away, and Jill is in 10 out of 10, 9 out of 10 pain all over. And despite escalating doses of opioids, her symptoms are unrelenting. She's not showing signs of toxicity, but she's definitely showing signs that she's now dealing with total pain and suffering because of her progression of disease. And the losses that she's grieving of her independence and her dog. She will continue to have physical pain, so we will continue to provide opioids, but we're going to explore the other aspects to her pain to make sure that we're treating them as well. The one thing here when it comes to total pain that I would really caution is that we don't use any phrases that suggest to the patient that the pain is in their head, because it's not true and it doesn't go over well. So I talk to people more about, you know, when your mood is low, what does your pain feel like to you? If you're alone, what does your pain feel like to you? If you're with someone watching your favorite TV show, how do you feel? That can be ways of exploring the other aspects to their pain experience. So for Jill, we'll start something for mood. We'll revisit her opioid use and encourage her to allow her home care to come in more so that her sister can be her sister instead of her caregiver. And in your last follow-up with Jill, she's now not eating and drinking and has started to have vivid dreams. Her pain's okay, but she's twitching and confused and hallucinating. And she's been really clear that when she gets to the stage where she's likely dying, she wants comfort-focused care. But unfortunately, she's showing signs of opioid toxicity. And I'm sure we've all seen this. We don't forget it when we see it. It can be in varying degrees of severity, but we'll see myoclonus, hallucinations, vivid dreams, confusion, and the one that a lot of people don't think about, which is hyperalgesia. So pain that's out of proportion with the physical stimuli. So the goal of treatment of opioid-induced neurotoxicity is to catch it early. So I screen everybody for it. So if you happen to be a home care nurse calling me someday and I say, are they toxic? I'm going to want to know that you asked about all these things, because that's how we keep track of it. So the treatment for toxicity is to get them off the offending opioid, but you don't want them to go through withdrawal or have a pain crisis. So we have to switch to a new opioid. And this is where sort of a part of to come back to your question about renal impairment. So if someone's on hydromorphone and they develop toxicity, you could try, if they were toxic on a Q6 dose, you could try for a day to go to a Q8 dosing and see if that clears it. And if it doesn't, you'll have to rotate, and that's okay. But I would rotate and go to Q8 dosing, knowing that a Q6 dose triggered trouble for that patient. The other thing is that if it's appropriate, you want to hydrate, you want to give the kidney something to work out to flush out those metabolites. And you want to rotate and dose reduce by about 20 to 30% or more if they're really toxic. And that's because when you start the new opioid, the body perceives it as being particularly potent because it's new. And so you can't just directly convert. And then depending on their goals of care and their prognosis, you want to figure out why this happened. So did it happen because you escalated the doses too quickly? Did it happen because a well-meaning family member said, oh, you're having pain, take more? Did it happen because they have an infection or they have hypercalcemia? Or they have new renal impairment from, hydroureter, from, obstruction of the collecting system. So these are things that you want to have run through your mind as you're treating the toxicity. And I'm just going to leave my opioid rotation slide up here for you guys. This will be in my slide deck for you guys to see. This is the conversion chart that I use. And I'm done. Sorry, I went over.